Friends, thank you so much for joining us again for this very important video of the Health Facilities Association of Maryland. I'm Joe DeMattos, and I'm going to try my best to facilitate the discussion today and stay out of it because we have three tremendous experts to share with you today. The purpose of today's video is to share new guidance on the use of monoclonal antibody. I can't say it. I have trouble with the phrase. Everybody does. Treatment for COVID-19. I'm joined today by Dr. Morgan Katz from Johns Hopkins. Dr. Morgan Katz is an assistant professor of infectious disease at Johns Hopkins. She is the director of the Antimicrobial Stewardship Program at Johns Hopkins Bayview Hospital. Her research has focused on antimicrobial stewardship and infectious disease prevention, specifically in the post-acute sector. She served on the long-term care as the long-term care incident commander at Johns Hopkins during this COVID pandemic. She is an original task force member for the Maryland state government with regard to our fight against COVID-19. And she served on the White House Nursing Home Commission to guide CMS protecting residents and staff in nursing homes in the early days of this pandemic. Dr. Katz studied medicine at the Maryland School of Medicine. She did her residences at Tulane University, and she did a fellowship in infectious disease at Johns Hopkins School of Medicine. She is board certified in internal medicine, and welcome, Dr. Katz.
Thank you so much for having me, Joe.
Our pleasure. Dr. Howard Haft often doesn't need any introduction, either in political, policy, or medical circles. I will just start off right from the bat to say that he's been licensed to practice medicine since 1974. So I just want to just say that right up front. He's been doing this a long time. He studied and got his undergraduate degree from Rhode Island, did medical school at Penn State University, did postgraduate internships and residencies at Brown University, has a master's degree in public health from Tulane University. Dr. Haft is board certified as a specialist both in internal medicine and emergency medicine. Dr. Haft, welcome. Thank you so much for making the time.
Thank you. It's a pleasure to be here.
Dr. John Loome is the Vice President for Medical Affairs at Genesis Healthcare. Dr. Loome has many appointments, including Clinical Assistant Professor of Medicine at the University of Maryland. Dr. Loome received his MD from Georgetown University. He did his internship and residency at Baylor College. Dr. Loome also completed a fellowship in geriatric medicine from Johns Hopkins University. Dr. Loome, welcome.
Thank you, Joe. Appreciate you having me. Thank you very much.
So Dr. Haft, there have been some changes in this antibody treatment and how it's administered, the clinical guidance, and really potentially broadening its use. Could you unpack that for us?
Joe, thank you. Yeah, there have been changes. I think one of the things that's been notable about this pandemic that throughout the last 18 months, everything has changed and changed on a regular basis, both the virus itself, as we know, through the, many variants and many different peaks, for perhaps in our fifth now, but also in many ways, the way that we adapt ourselves and treat the virus and combat it has changed considerably. And it's true for every aspect, and particularly true also for monoclonal antibodies. So what I'd like to do is just go through very quickly some slides that will be able to be shared later, I'm sure, to discuss kind of the trajectory of monoclonal antibody therapy throughout the pandemic and where we are now, which is we've landed, and I think in a place where there's much broader application for this important therapy. Thank you, Hope, for putting the slides up. Let's go on to the next one. I always like to start out with this disclaimer that, as I said, things change rapidly, and the information that's provided here was accurate as of August 25th. I think you'll see in a slide later on that even in the last week, this has changed again. Let's go on to the next slide, please. So first, just as a reminder, monoclonal antibodies are antibodies that are produced in a laboratory that are specifically directed against COVID, particularly against the spike protein, which we know is the place that allows this virus to enter cells and is really the target for most of both our monoclonal antibodies and for vaccines. That they are most beneficial, and this is really important to remember, when they're given as early as possible in the symptom progression, or as early as possible, we'll find out later in the discussion, when someone is exposed, an unvaccinated individual is exposed to this virus, or to someone carrying the virus. It's delivered, initially it was delivered only by IV infusion. And one of the things that we'll talk about that's really important now also is we've noticed that it can be equally well delivered by subcutaneous injection. Importantly also, this is not a substitute for vaccination. It is a treatment for those individuals who are symptomatic, and we'll find out later also for those who've been exposed. But initially it was for those who are symptomatic and who are test positive for COVID and are at high risk for progression to get worse enough to progress to be hospitalized. So it's not a treatment for those who are hospitalized, but it is a treatment for ambulatory patients. It's been shown in both phase 1 and 2, and then in phase 1, 2, and 3 data that it is effective, and that was the basis of the EUAs that were initially developed in November and then expanded several times based on additional data that became available. And I think Dr. Katz will speak, I'm certain, eloquently and specifically to the data that supports this, the use of these medications. Next slide, please. So let's first talk about the indications for those who are confirmed to have COVID infection. Next slide. So the products were granted EUA for mild to moderate COVID cases early on in infection for those who are at risk for progressing to severe COVID and or hospitalization with a specific eligibility criteria. They needed to be adults or pediatric patients who were greater than 12 years older or of age and weighing 40 kilograms or more. They needed to have a confirmed positive test, and that could be either a PCR test or an antigen test. And importantly, antigen tests are acceptable here because remind people that that time is of the essence. The sooner this therapy is applied, the better chance it has to combating the virus. The lower the viral load and the greater the ratio of antibody to virus. So time is of the essence. The treatment also is for symptomatic patients who have not progressed to the point of requiring hospitalization. This is to say, again, that if someone's in the hospital, this is not the treatment for them, at least not at this time. There is no clinical evidence that this is effective for those who progress to hospitalization. But it's also not effective or appropriate for those who are just on the cusp of hospitalization. If someone requires oxygen because of COVID infection and they didn't require oxygen before, this is not the treatment for them. Or if they were on oxygen and it needed to be increased in order to keep them sufficiently well oxygenated, they need to be in the hospital. This is not the treatment for them. Next slide. So here's a kind of the linear place and the time frame for changes in the use of monoclonal antibodies. As I said, November of 2020 was the initial EUAs for both Eli Lilly's cocktail, BAM, Atesi cocktail, Regeneron also. And then in May of 2021, there was expanded eligibility for the administration of both Eli Lilly and Regeneron, allowing for work for patients to be eligible outside of what I will show you is a very prescriptive list of things that were in the original eligibility list for Regeneron and Eli Lilly's products. And it expanded to use more clinical judgment. And in June of 2021, monoclonal antibody was expanded to include the use of subcutaneous administration. And then in July, so you can see rapid succession of things changing again, an indication for post-exposure prophylaxis, which both the sub-Q use and the post-exposure prophylaxis were real game changers, expanding the real capabilities of these monoclonal antibodies. Next slide. So here were the high risk factors on the left-hand side that were in the original list of what made people eligible. As you can see, I won't read them all, but there's quite a broad list going from older age. So we know many people are over 65, and that's a big bucket of people. And obesity, people with BMIs, great adults with BMIs greater than 25, and appropriately BMIs that were significantly elevated in youths. And then another long list of conditions. But what we noted early on is that there were many individuals who their physicians or their caregivers, professional caregivers, felt they really are at high risk, but they don't fit neatly into these categories. So the expanded indications on the right-hand side in bold indicated that it could be other individuals based on race and ethnicity or other known conditions that the care provider knew about, that they felt were made the person eligible for monoclonal antibodies. So it really opened up the funnel much more widely. Next slide. So now that there was an expanded capabilities to give monoclonal antibodies based on clinical judgment, but now in the last few months we have these new indications and these new abilities to give sub-Q. So let's talk about post-exposure prophylaxis and what that looks like. Next slide. So the indication for post-exposure prophylaxis is that it's for vulnerable persons, those with this list of vulnerable individuals that we just talked about, including those who would be clinically indicated to be vulnerable, but those who are not fully vaccinated. So it could be someone who's unvaccinated or someone who's been partially vaccinated, or it could also be someone who's been fully vaccinated, but not felt to be able to mount a complete immune response. That is, people who are on immunosuppressant therapies, people who are in cancer therapy, people who have cancer themselves, and basically that long list, which includes clinical judgment of those individuals who were not expected based on the vaccines to mount a sufficient immune response. So all of those individuals, if they've been exposed to someone who is known or suspected of having COVID, would be eligible for use of Regeneron as a prophylactic, as a post-exposure prophylaxis to prevent them from going on either to get COVID or to get severe COVID. Been shown in studies, and I think Dr. Katz will talk about this in more detail, to be effective. And those studies have included the use of subcutaneous as well as IV use for this. And you can imagine that subcutaneous is a much more easily administered and perhaps more readily available, particularly in congregate facilities. This is also not eliminating the use of active COVID, active treatment of Regeneron and the bam-atesi for use for active cases, that is, people who are symptomatic, test positive, and are vulnerable. There's also a third monoclonal antibody that's in the environment now, so Trovimab. You can see the line here says that bam-atesi has been paused in Maryland. I'll talk about that on the next slide. Next slide, please. Or in a subsequent slide, and tell you how quickly things change. So here again is the eligibility for post-exposure prophylaxis for Regeneron. And it says all the things that we just talked about, but it has a specific indication you can see here, which is very highly relevant to skilled nursing facilities for those who are at high risk for exposure can be treated. That is, individuals who meet those other criteria, but anyone in the facility who comes up positive for COVID would make anyone in that facility who fits into the criteria, that is not immunized or incompletely immunized and vulnerable, to be a candidate for either sub-Q or IV post-exposure prophylaxis. This is another unique indication for congregate facilities like nursing homes, assisted living facilities, prisons and jails, etc. So it really opens up the funnel again much more widely to help prevent people who are in these facilities from growing worse, requiring hospitalization, or potentially dying. This is so important now that we're seeing, again, an uptick in these cases where, that are because of the Delta variant and other reasons, that now can again prevent worsening conditions and hospitalization. Next slide. This is just recounting the eligibility. Just I call your attention to the bottom paragraph of what is considered close contact. Well, within skilled nursing facilities, it's being a case within the facility. So it's any outbreak, which is any one case, as you know. And in general, in the general public, it's close contact, which was being within 6 feet of an individual for more than 15 minutes or more in any 24-hour period. Doesn't need to be contiguous 15 minutes. Or any being in contact with someone who is closer contact, such as hugging, kissing, sharing, eating, or drinking utensils, or getting respiratory droplets if somebody sneezes or coughs on you. That's also considered obviously close contact. But again, within skilled nursing facility or congregate care facilities, it doesn't require that level. It's anyone within the facility. This is a good lesson we learned from even with the best infection control, there can still be lapses, and we want to make sure we're comprehensive and not pigeonholed into one narrow definition. Next slide. This is I won't spend any time here. This is a recap of the indication for Regeneron and talks again about about its use broadly in skilled nursing facilities, both sub-Q, IV, and for post-exposure prophylaxis. Next slide. Here's where the update comes. This was Tessie was paused because until recently, we had more than 5% of the beta and gamma, variants of the virus in Maryland, although we were predominantly Delta. It was paused in all of Region 3. Within the last hour, CDC changed the guidance on, or HHS rather, changed the guidance on that and said it's no longer paused in Maryland. So what I said, the disclaimer that this was accurate, this presentation as of August 25th, as of September 3rd, it is no longer accurate because Tessie is no longer paused here in the state. Next slide. Just a quick overview of the Maryland program. Next slide. We have 3 branches of our state program. In the state oversees kind of in a coordinating and technical assistance version of this. The antibodies themselves are ordered directly. They're not allocated by the state. They're ordered directly from either the manufacturer or through the distributor, AmerisourceBergen. But we have 3 branches. We have the existing hospital clinical spaces where hospitals are providing that. There's about 16 hospital-related infusion sites around the state that we work with on a weekly basis. There were as many as 32 that retracted during the downturn. We're building them up again to add more capacity across the state. We work with the congregate care facilities through HFAM and the associations, and directly and through their pharmacies. And also through the state's TAT teams to support the use of monoclonals there. And then there are many community access points, which include some urgent care centers and some primary care offices that also we work with closely to administer monoclonal antibodies, particularly now since subcutaneous administration is available. Next slide. I won't spend any time on this. You all know about your pharmacy partners and home infusions and vascular access. All of those have been brought to the fore in order to make sure that there is readily available monoclonals available in skilled nursing facilities. And I call to your attention now that facilities can also order directly the Regeneron through AmerisourceBergen. It has a long half-life, shelf life, and can be administered sub-Q. So it makes this a his, hers, and ours version. You can use pharmacies, or you can use it directly at the facility through your own staff. Next slide. And this was the schematic we used for ordering through the pharmacies and using infusion contractors to help when that was necessary. Probably still more applicable to the assisted living facilities. Next slide. Really important, and I think we'll talk more about this in the questions and answers, about getting the word out about the ability to use these both to residents, to staff, and to the public in general. So I'm not going to spend any time on this because I think we'll talk about this more in the questions and answers. Next slide is about communications. And I think I'll end here because I'm really eager to have a conversation with my colleagues, Dr. Katz and Dr. Loome.
All right, I'm going to try to do this better, Dr. Katz, because I want to draw you into the conversation. I'm going to look at the word monoclonal antibody treatment. I did it much better that time. But given the new clinical guidance that Dr. Haft just unpacked, how does this influence you, your practice going forward?
Yeah, so this is such a great question, Joe, and I want to thank Dr. Haft too for a really great overview of this treatment. So the first thing I guess I want to stress is that though this is an incredibly helpful medication, it should not be considered a replacement for the push to vaccinate. It should not be considered an alternative to vaccination. And we still need to be going a full court press towards urging our residents, our staff, and the community to get vaccinated. That being said, I do think the opportunity to use monoclonal antibodies as post-exposure prophylaxis really does open up a lot of potential opportunities, particularly in the congregate living settings. As we all know, transmission of the virus that causes COVID-19 can be incredibly rapid in long-term care settings, particularly if the facility does not have a highly vaccinated population. So the chance to prevent transmission of this disease using the antibodies as post-exposure prophylaxis is exciting. And we can kind of frame it as similar to how we use Tamiflu to prevent flu transmission in long-term care. So it's certainly enticing, but I will say there's, I have a few sort of distinct pieces of advice for medical directors or facilities that are thinking of using these that we've seen sort of across the board. Number one is know your residents. So have a clear list before an outbreak, before you're in a situation that there's an exposure of residents that are unvaccinated, residents and staff that are unvaccinated or are considered immune compromised that may benefit from post-exposure prophylaxis. Probably the majority of residents in a facility are going to qualify for monoclonal antibody therapy if they are infected. But for post-exposure prophylaxis, remember that this is for people that are unvaccinated or partially vaccinated or cannot mount a response to vaccination. So really having a sense of who that is important. And then know the process for getting the antibodies. So a lot of the facilities that I've worked with have actually gone ahead and gotten consent for the antibodies before an outbreak or exposure and had them on the chart. And this is a really nice way to prevent delay in administration of the antibodies. It can speed the process and get residents treated sooner rather than later. And important to stress here that the earlier you treat with these antibodies, the better. So we really want to make sure that we're expediting that process if they're indicated, which is where sub-Q injections can sort of come into play. And then I'll turn it back over to you, Joe, and we can talk about sort of the modes of injection down the road.
Thank you, Dr. Katz. Dr. Loome, how does this impact you, your practice, and your work with other physicians in the work that you do?
Thank you, Joe. And thank you, Dr. Haft, for the great presentation, and Dr. Katz for your comments. We are experiencing at Genesis in many states, not, and specifically not Maryland, I believe, because Maryland has such a great vaccination rate to begin with, but we're seeing positivity in our patients who have been vaccinated in the past. Those patients who do become positive we're seeing them hospitalized. And unfortunately seeing very few deaths in the frailest of the frail. Now, given that, this has been a game changer because we are getting the monoclonal antibodies to patients who become positive and their close contacts pretty much within 24 hours. And since doing that, seeing much fewer hospitalizations and virtually no deaths in that population, and finding at the same time that it's a very safe treatment, very well tolerated. But I think Dr. Katz made a very, very good statement that I was going to start with, but she obviously beat me to it, and it's great hearing it from her as an infectious disease specialist, that we're not looking at this in any way as a substitution for vaccination. We mandated vaccination of our employees 2 weeks before the White House announcement about it, and really tried to take the lead on that. And so we've been able to push our vaccination rates up above 90% for our patients. We're above 90%, obviously 100 soon for our staff as well. But the monoclonal antibody has been great, very well tolerated, very effective, especially at preventing hospitalizations and death.
Thank you, Dr. Loome. Dr. Haft, I'm going to bring you in a moment. I'm going to ask you two questions and ask Dr. Katz and Dr. Loome to think about these questions as well as we cycle around. One question is way, way, way above my pay grade, but important in this discussion. And Dr. Katz teed it up. And the second sort of right in my wheelhouse. The one that's above my pay grade is that what is in your presentation, Dr. Haft, it seems that a couple of the major changes is that we can use this treatment. Physicians now can order this treatment prophylactically, and it can be administered not just by IV, but by subcutaneous injection, just below the skin. So the question above my pay grade, Dr. Haft, is to talk about those methods of delivery. And to tee up that Dr. Katz, Dr. Loome, we're going to ask you those same things. So first is about those methods of delivery. And then second, Dr. Haft, as a practicing physician, going back to 1974, what would be your message to consumers and families about this treatment? Oh, and Dr. Haft, you're on mute.
Somebody muted me. I didn't mute myself. I want to put that disclaimer.
That is correct. That is absolutely correct.
Yeah. And before I answer those two questions, and I want to just join my colleagues by saying loud and clear that this is not a substitute for vaccination, nor is it a substitute for third doses or boosters. It is not any of those things. Those things are the priorities. This is for exactly what we said it was for. It's for treatment of active cases or post-exposure prophylaxis. To the issue of the route of administration, Joe, it's a great question, and I think it really goes back to really practical considerations, and both IV and sub-Q are effective. The practical consideration is how quickly you can get and how practically you can get this medication into an individual or individuals in the setting that they're in. If there's no barrier to using IV, that is, and we see this often in the ambulatory setting, a doctor will diagnose a patient, they'll connect them up through the referral system to one of our monoclonal infusion sites. The infusion site says, come on in tomorrow and we'll get you. And that's perfectly fine. Those are usually IV, unless they can't get an intravenous line in, which happens, and then they use sub-Q. In a setting, in a long-term care facility where there might be a delay, particularly with vulnerable patients, the answer may be completely different. It may be, let's use sub-Q here. Really, it's about using these treatments, which are essentially equally effective. It's the same medication, just a different route, but getting it into the individual as quickly and efficiently as possible. I don't know that then perhaps Dr. Katz does of any studies that do inferiority studies or other studies that have shown any kind of difference between those routes of administration. So I think those are, those are equally important. To the question of how to communicate, I will have to tell you that this has been a great frustration of mine throughout this monoclonal campaign, is that we have not been able to effectively communicate to the general public. Some of that is because I think vaccines appropriately took front and center stage, but in some ways they took the whole stage. And then there were other controversies with with outbreaks and waves and political issues that never really allowed the public to focus on monoclonal antibodies. Also, just as you have trouble saying that, monoclonal antibody, people have trouble wrapping their minds about what the heck is a monoclonal antibody. Vaccines have been around for 200 years or more. Everybody knows the word vaccine. Monoclonal antibodies, although they've been around for a decade or more, are not things that roll off people's tongues, and you have to get them comfortable with that. I don't think it's an issue necessarily of hesitancy, as you pointed out in the couple of states that where there's been wide hesitancy, but they're embracing monoclonal antibodies. I don't think it's that. I think it's public recognition. We just need to do a better job and perhaps better ways to communicate to the public about this is the only treatment that's available for, and the only prophylaxis that's available for this therapy for ambulatory patients. We just haven't been able to. We need to do better about communicating that. Doctors do, and public health and the industry does.
Dr. Katz, what are your thoughts about delivery method and consumer messaging?
Yeah, so I just want to follow up on the consumer messaging, because I agree. I've had the same experience. I've even had, family members and friends reach out to me, and I think they say, I feel fine after they get infected. They think that they are asymptomatic. Even though they qualify for monoclonal antibody therapy. And so because they feel good, they decide not to go get therapy. And I think what is really important to highlight here is that, yes, symptoms of COVID are often mild in beginning stages of the disease, but they can rapidly progress. And the point of monoclonal antibody therapy is to prevent that. And so 100%, I have been trying to get the word out, and certainly to get the word out to physicians, medical directors have a very low threshold to treat. We know that this is well tolerated. If you qualify, I unequivocally tell people, even if they feel good right after they test positive, to go ahead and get referred for therapy, because we have seen significant effects in terms of preventing hospitalization and death for treatment. And then to talk a little bit about the post-exposure prophylaxis, which I think is really exciting. So just to kind of put this in perspective, so the studies coming out on post-exposure prophylaxis did use subcutaneous injection. And so that should make us feel better about using that in the nursing home setting, where it may be much, much easier to get it to your residents. Some facilities only have LPNs. It's more challenging to get IV access, and so it's well, not only, but with staff shortages, et cetera, it's sometimes very challenging to get IV access. So the sub-Q injection should and can be used there. So just to, give you some numbers, we have the initial studies on post-exposure prophylaxis saw a relative risk reduction of 81.4% in the group that received Regeneron therapy versus the placebo group, and a 92% relative risk reduction in symptomatic infection. So pretty significant and definitely compelling to really use this therapy. That was for household context, but I truly believe in a congregate living setting, this is really the area where this could be most effective. And to start thinking about post-exposure prophylaxis for household context as well, and get that out to the community.
Thank you, Doctor. And you also mentioned something earlier that I wanted to highlight as I pass the baton to Dr. Loome, and that is that we have seen some best practices in the skilled nursing and rehab setting in terms of involving patients and families in discussions in advance of exposure so that you have consent forms in place at the time of exposure, and you can move quickly in advancing the treatment. And I think that's something that's important for the physicians, for the operators, and for the patients and families in our setting. And Dr. Loome, in terms of administration of the treatment and messaging to families and consumers, what are your thoughts?
Well, we're very excited with the latest EUA on post-exposure prophylaxis, including the subcutaneous administration, because, I mean, let's be honest, in the nursing home setting, we all know as clinicians, it's been a challenge in many instances to obtain IV access for a variety of reasons. Staff abilities, capability. You have, patients that are in the nursing home setting are very difficult to obtain IV access a lot of times because of their anatomy and their given comorbidities. So we've looked at this as a game changer in terms of preventing delay and telling people that if the patient is a candidate for the monoclonal therapy, to make sure that you do not sit on the drug and do not administer it to the patient because you cannot obtain IV access, or it's going to be a significant delay to obtain IV access. That subcutaneous route is there, and it's there for their availability. So we're starting to see the uptick in that route and utilizing it that way.
Got it. Really appreciate those. So I'd like to just do one more round robin and ask the three of you individually if there's anything that you'd like to share to your colleague physicians, to the operators in our setting, to the teams or the families in our setting. There's no perfect answer. I just want to make sure that no comment or insight is left unsaid. And just to change things up, after Dr. Haft, I'm going to go to Dr. Loome. And so you're going to have the last word, Dr. Katz. But Dr. Haft, what would you like to share now for your colleague physicians, the workforce in our setting, or families and patients in our setting?
So just two things, really. One is make every effort to get both the staff and the residents vaccinated. And when it's time, and it will be time very soon, to revaccinate, third dose, boosters, whatever you want to call it, make sure that there's rapid adoption of that also. That really is the first line of defense. And secondly, think about the monoclonal antibodies, and not only think about them when it's too late, start thinking about them early. Educate the staff, educate the residents, the families of the residents, get those consents, and because the treatment of this disease, whether it's post-exposure prophylaxis or active treatment, is always best done early on. And those delays that are caused by waiting for either for medications to arrive or for consent to come can really be significant impacts on the patient's health.
Thank you, Dr. Haft. Dr. Loome?
Yeah, these, our patients in the nursing home are at the highest risk of any population. We have to be liberal with vaccinating patients. Like Dr. Haft said, leave no stone unturned there. If patients, I see no reason why when our patients become positive, we don't use monoclonal antibodies right away and look into who those close contacts are, those patients who in-house who are at the even higher risk than anyone else, those that are immunosuppressed and need that protection to make sure they get monoclonal antibodies as well, even if they're not positive. So, again, be liberal with your thinking on this and use every tool that we have in our arsenal.
Outstanding. Dr. Katz?
Yeah, I guess I'd end with a couple things. First, I would say protect your staff as well. So a lot of staff working in nursing homes, assisted living facilities have comorbidities that may put them at risk for severe infection. They are still getting infected now. So make sure that they're aware of the monoclonal antibody therapy and they can be offered that therapy if it's indicated. And then in terms of, I'll just really end on the vaccination point. Vaccination is your own body's immune response, creates your own body's immune response to the virus. These monoclonal antibodies are, sort of a synthetic response. It's always going to be better if it's coming from your own body. And if you have a resident or a staff member that consents to monoclonal antibody therapy and not to the vaccine, I would really push them to understand that you're going to have a better response to this infection from your own body rather than, something synthetic. So make sure you're having those tough conversations, make sure you protect your staff and, keep at it. I'm sorry that this is still going on. Thank you so much for having me.
Well, Dr. Katz, thank you very much. And thank you, Dr. Haft and Dr. Loome. I think Dr. Haft, you mentioned that in terms of epidemiology, this is our 5th round of fighting COVID-19. And we really do want to get it on the ropes and knock it out to the extent that we can. We know that COVID is part of our new life and clinical reality, but vaccination is our #1 tool in saving and protecting lives. And these new use patterns and guidance for monoclonal antibody treatments really will also save lives. And I just want to point out to the physician leaders, the leaders in skilled nursing and rehab centers and assisted living campuses, and the teams that will watch this video, I want to point out to them that this partnership that this video represents, the best and the brightest thinking in academia scholarship, 3 practicing physicians, government, scholarship, medical practice, and the sector all working together as we have throughout this pandemic to protect Marylanders in need, and that you can count on. So thank you all very much. Stay safe, be well, and we'll see you soon.